Sorry.
And of the dance. Friends, it's a great pleasure to welcome for the special talk on pediatric anesthesia my colleague from JJ Hospital, Dr. Ushali Ponde and her team. Friends, we keep moving forward, opening new doors and doing new things, as we are very curious just like children. Children are some special things for anesthesia. They are not only small adults. It is very difficult for them to separate from their mother. Very delicate to handle, and surgery make anesthesia and pain management really tough. And that's why pediatric anesthesia has become a separate subspecialty of our branch. Dr. Ushali Ponde, she's been called upon as an expert for very difficult, complicated and high risk and VIP patients at various tertiary care hospitals in a city like Bombay. And I am very sure, I am very confident, and we will be definitely more wiser after being enlightened by this invitee and learned faculty. I welcome Madam. Thank you.
I'll be talking on CO inductions, how we actually do it in pediatric patients. I was told that this has to be a very practical topic, so I will actually show how we actually induce patients in induce of pediatric patients. This is a disclaimer. All necessary permissions for the videos has been taken, and parents have consented for the videos. Now, the lecture highlights. I would be dividing the lecture in 3 parts. Initially, I would be talking in brief about sevoflurane physical properties. Then I will be demonstrating some videos of how we actually do sevoflurane induction in our patients. And then I will be doing a brief review of literature on certain controversies regarding sevoflurane. Now, that sevo is a preferred agent for induction because it's a non-irritating and has a pleasant odor. It has low blood gas solubility. The incidence of side effects like laryngospasm, cough, breath holding at inductions is much lesser than other induction agents, especially halothane. The initial excitation and dysrhythmias which can be seen with halothane are also lesser with sevoflurane. Now, it's a preferred agent for maintenance also because of its low blood gas solubility, its cardiovascular stability, and it does not affect breathing significantly. Also, whenever depths of anesthesia needs to be changed, rapid depth adjustment of depth can be done because of the FD-FA ratio of sevoflurane is much lesser than that of isoflurane. Also, for recovery, the recovery is smooth and rapid recovery with sevoflurane because of the low blood gas solubility, and it does not affect breathing significantly. So, whenever you maintain spontaneous respiration, the breathing is easier to maintain with sevoflurane than with halothane. Now, there is something called as the volatile induction and maintenance of anesthesia. Now, this is the concept in which you don't use any IV agents. You use only induction volatile agents for induction as well as for maintenance of anesthesia. This is possible with sevoflurane. They say that sevoflurane provides also hypnosis, analgesia, and relaxation. So everything can be done only with sevoflurane. Before we start, for any good induction, the child has to be pre-medicated properly. Conditions for the child, like he has to be explained how he'll be given a mask and all, so that he is prepared for the OT and he doesn't come crying inside the OT. The child is very calm and he is being wheeled inside the OT even without the parent. The oral pre-medication takes around 30 to 40 minutes to act. steady is also with the child. He's laughing and he doesn't realize that he's been taken inside the OT. And now we work in all sorts of conditions. There are places and nursing homes where you don't even have a closed circuit. You have a sevoflurane vaporizer, not even a closed circuit. Now this is an anesthesia workstation with a closed circuit but no ventilator available, right from BIS monitoring to everything. So wherever you work, your induction should, you should be able to induce the child. Now this is how we do our inductions. Now CO inductions are of three types. First is tidal volume induction, second is vital capacity induction, and the third is overpressure induction. Now the difference in all these inductions is that in tidal volume induction, what we do is you start a sevoflurane at 1% and the child is breathing at his tidal volume. And we do in pediatric patients is called as an overpressure induction. So in overpressure induction, what is done is child is asked to breathe just rapidly. So he cannot take a tidal volume breath, he may or may not cooperate. So that is called as an overpressure induction. That is what is commonly followed in pediatric patients. Now in tidal volume induction, as I explained, it's a conventional induction. You start at a low concentration of sevoflurane and gradually you start increasing the concentration. The fresh gas flow is constant. The outcome is slower induction and the volatile anesthetic that is used is much higher in tidal volume induction. So this is a tidal volume induction. This is a 4-month-old child posted for a tenotomy. Now what I want you to see is that we don't have hi-fi gadgets like BIS monitoring or your sevoflurane end tidal concentration, but still we do a very good induction. So what you need to observe is his breathing pattern. Now in this, the fresh gas flow is around 3 liters per minute oxygen nitrous. Initially you can see his breathing is irregular. So this signifies a light stage of anesthesia. Gradually we are increasing the concentration of sevoflurane. Gradually it's been increased to 8% and in 30 to 35 seconds you will realize that his breathing would be just as it was pre-induction. Now this is the time you should take any IV line or you should do the procedure. Like if you try doing any procedure or if you break the child before his breathing is normal, then that is the time you have a laryngospasm. So most of our inductions are done most of our inductions are inhalational inductions without an IV line, and once an inhalational induction is done, we take an IV line. Now you can see the breathing pattern is improved. So this is the time you start pricking the child. I hope everyone can appreciate that. So this is good breathing. Like this is the time you should start taking your IV line. If you try taking an IV line before this kind of breathing, then that is the time you have a laryngospasm and you are left with a laryngospasm without an IV line. So we have this technique of tying our mask. So this is how we tie our mask. So even if you are alone in the operation theatre, you can just tie the mask with the mask that we usually wear, and you can manage the child even single-handedly. I mean, the child is breathing spontaneously, and I can, I am myself taking the IV line. Now before we do a sevoflurane induction or your single breath or your overpressure induction, what you need is a circuit preparation. So for circuit preparation, what you have to do is you have to pre-fill the circuit with sevoflurane gas. To do that, what we do is the flows are kept at 6 to 8 liters per minute at 1:1 concentration. The sevo vaporizer is kept at 8%. Generally the time taken is around 40 to 45 seconds. And the balloon has to be emptied at least 2 to 3 times for the circuit to be completely filled with sevoflurane. Now this is how circuit preparation is done. Now this place has an end-tidal sevoflurane monitor. So you increase the sevoflurane to 8% by using the closed circuit. The initial concentration end-tidal sevo, as you can see, was 0. Now it's been increased to 7-8%. The flows are at around 3 liters of oxygen and 3 liters of air. Now I have blocked the circuit, and you empty the balloon at least 2 to 3 times. You continue this procedure for at least 40 to 45 seconds. Because if the circuit is not pre-filled, then your overpressure induction or your single breath induction is not possible. So once the balloon is emptied, the end tidal CO would go down again, and again it would start increasing to 7-8%. Now coming to vital capacity induction. Vital capacity induction, as I explained, is a single breath induction. You need a full circuit which is filled with sevoflurane. The mask is kept on the face, and the patient has to be very cooperative for your single breath induction. So the patient should be able to take a vital capacity breath. That is, he has to exhale maximally and then inhale maximally, and he will go up to sleep in 2 to 3 breaths. Patient cooperation is a must in this case, which is not always possible in pediatric patients. So as I explained, what we do commonly is an overpressure induction. In this, you keep a high volume sevoflurane. Start with fresh gas flow at 3 liters per minute, and the sevoflurane concentration is directly kept at 8%, and the child is asked to take just deep breaths. He may not be able to take a vital capacity breath, but he will be able to take a deep breath. The result is a rapid induction. So this is a technique of overpressure induction. So this is the same child which we built it inside the operation theatre. The induction is done with a closed circuit. The circuit is already pre-filled with, the flows are kept at 3 liters per minute. The sevoflurane concentration is directly kept at 8%, and the child is asked to take deep rapid breaths. So the inductions are much faster with this kind of induction. Now he was posted for an orchiopexy surgery. We have tied the mask as I have already demonstrated before. Since it's an orchiopexy surgery, we give a caudal block. The volume is around 1 ml per kg. So with this technique, I am able to manage the child single-handedly, like there is no other person in the operation theatre. The child is breathing spontaneously. You can monitor his breathing in the bag. The end tidal sevoflurane for your caudal block is around 3.5. Once the caudal block is done and the block has acted, then you can reduce the sevoflurane concentrations to around 1.5. 1.5% is the minimum to prevent awareness. But since you have given a caudal block, you can go even lower. As you can see, the vitals are extremely stable. It has a nice ETCO2 pattern. The surgeon has started operating. Now we have reduced the sevoflurane to 1.5. The flows are reduced to 1.1. His vitals are all stable. The end tidal sevoflurane has come down to 1.5 now. Now the surgeon is finishing the case now. We are at the same flows. We have stopped the sevoflurane now. His vitals are still very stable. So we have managed this case only on a face mask with sevoflurane only and a caudal block. So there is one technique called as coasting, which we commonly use. This is very useful technique for your short procedures. So once you have your induction is done whichever induction you do, once your induction is done and you have say you have around 15 to 20 minutes left for the procedure to get over, what we